Assalamu alaikum. Good morning, everybody. Thank you for inviting me today for the second year to present at your prestigious conference. Being a speaker in such a, I would say, strong and efficient society is something to add in my CV. I am presenting the Saudi Critical Care Society, the Neurocritical Care chapter, and I also work in King Fahd Medical City and being the chairman of the first neurocritical care department in the country. So my background, I'm a neurologist and an intensivist, and I had neurocritical care training. So bear with me. Am I the only neurologist presenting at this conference, or there's other? I'm not sure.
No, there is pediatric neurology.
So pediatric neurology, good, excellent. I'm not the only neurologist. Thank you very much, Amr. طيب, Bismillah ar-Rahman ar-Rahim. Let's talk about a concept. Money?
Yeah.
Alhamdulillah. So this is indicating, alhamdulillah, good relations with neurology and neurosurgery. I'm going to talk about autoregulation. This concept probably applies to more diseases, many diseases, but the fundamental part of autoregulation, or the basic science, comes from the traumatic brain injury module, which is a module that human being recognized since early days because of the battles, the trauma. So the people were able to study the module in traumatic brain injury better than other modules. But this module is extendable to other diseases. Being of interest today in trauma, I will explore the background and also highlight some concepts that may help understand the autoregulation and manage the patient according to his capacity and his or the reservoir of his autoregulation. So every physician would love to have, as a clinician, would love to have a vital sign. This vital sign should be representing something in your line of management. So you would love to know the temperature. If you have patients with sepsis, you would love to know the respiratory rate and saturation in somebody with lung disease. You want to know the blood pressure in patient in shock. And you want to see the pulse regularity and rate in patient with arrhythmias. And again, pain is one of the vital signs that is added for patient with trauma or ischemic limbs. So you would love to know a vital sign, and this vital sign will guide you through the management all the way. But nobody has figured a vital sign for a sick brain or an injured brain. So what vital signs you want to measure every hour or every day or every 12 hours, every shift when you hand over the patient and take over the patient next day? What are the vital signs of an injured brain that you want to use as a surrogate of that indicates the patient is getting better or getting worse? Since medical school, everybody would always highlight the cerebral perfusion pressure value in the management of patient on traumatic brain injury. And basically because in our standing, the ICP contributes a lot to the perfusion. So instead of depending on the map or the systemic blood pressure, you have to understand, estimate, or measure the cerebral perfusion pressure. And it has other components. It has the cerebrospinal or the cranial compensatory reservoir, which is left after trauma. The ability of the autoregulation system, I would say, to handle such trauma. How much is left of the brain to manage a situation. And then the vascular reactivity. All together contribute to the cerebral blood flow, which is a surrogate here of good perfusion of a sick brain. This is the compartment of a skull. You will have the brain tissue with their intracellular fluid, the extracellular fluid, the blood, and the CSF. And again, the vascular reactivity component, which is different to other vessels in the body, it has a neuronal component. This neuronal component has both the ganglionic part and the parenchymal part. So there is the trigeminal nucleus that has an impact on the vascular tone, and the module comes from patient with migraine headache. And there is the intraparenchymal part, which has also neuronal component, mainly by innervation by the astrocyte. So what is different in this vascular system? It has a stronger neuronal component. Apart from the endothelial compartment or endothelial system that reacts to the endothelial injury or vasodilation, and the microvascular communication when you have ischemia in the distant part you get a compensation by other part of the vascular system. Again, I will make this slide short. We have chemical component, which is the partial pressure of CO2 and OPO2, the neuronal component, and again, the metabolic component regulation, which is the liberation of the hydrogen ion when you have acidosis. All of this autoregulation keys contributes a lot to the response of the blood pressure, systemic blood pressure. When the blood pressure goes to the intracranial compartment, the response of the brain is different based on those key elements. So the normal curve is that to have a steady cerebral blood flow, if you have a MAP, mean arterial blood pressure between 50 to 150, your system fails at a point. That point causes either constriction or dilatation. So if you have constriction, you will end up by having ischemia, regardless of the ischemia, either global or focal. And if you have dilatation, you will end up by hemorrhages or brain edema. You can have focal bleeds, or you can have generalized brain edema. So this is the response, the brain, this is the defense mechanism for the brain to respond to the variabilities of the blood pressure. And this autoregulation can be shifted from one side to side, basically on the status of the patient. Is he a chronically hypertensive patient or not? So the set points is not fixed for everybody. When this system of defenses is in failure, you will have a linear relation between what is pushed from the heart to what happens inside the brain. So any increase in the systolic blood pressure or the MAP will eventually lead to higher pressure in the intravascular compartment. And this will end eventually with a sequelae, either brain edema or bleeding. And if you drop suddenly, the autoregulation cannot maintain a steady cerebral perfusion, cerebral blood flow, and this will end up by ischemia at an earlier point. So instead of having this at 50, you will have the ischemia starting at 75. So even if the patient in the monitor looks to be normotensive, he may be having threatening ischemia to the brain. This module of autoregulation impairment was seen in other pathologies, not only the severe head injury, but also hemorrhagic or ischemic stroke, space occupying lesion with vasogenic edema, CNS infections, and neonate with low birth weight. So what happens, or what is the most likely period that this system is impaired? So the scale here is the numbers from 1 to 5 indicate days. So the majority of patients will have impaired autoregulation in the first 2 weeks. And almost 50% of them will have it in the first 4 days. So remember now that the damage, usually either impaired autoregulation or complete absence of autoregulation, will happen in the first 48 hours. And here, at this point, you need to optimize the cerebral perfusion pressure. You need to measure it. In later days, the patient will start to recover. In fact, the autoregulation will start to recover, and patient will have more correlation between systemic blood pressure and his cerebral perfusion pressure. The impairment of an autoregulation system has 3 risk factors, or there's, I would say, correlations. The first one is the high ICP. So if you don't have a controlled ICP, the lower line below, you are most likely, if the ICP is not controlled, you most likely will have an impaired autoregulation. So remember though that high ICP, if not controlled in the first 2 weeks, will end up by impaired autoregulation. The second contributing factor is a diffuse injury. So if you have a diffuse pathology at day 4, you will see the discrimination. The line below is the diffuse head injury, while the line above is the focal head injury. So if you have a diffuse pathology, you will see your autoregulation impaired and will last longer. And again, the third contributing factor or association, I would say, at this study is the glaucoma scale. The cutoff of glaucoma scale less than 6 indicate, the lower line indicate that your autoregulation will probably be impaired and will continue to be impaired for the period of probably 2 weeks. The many phases of an injured brain. I always keep this slide to tell you that your patient is dynamic. You receive the patient in day 1, and you see the patient differently in the second week or third week. So definitely, if the patient is dynamic, your management as a physician should be dynamic. You have to have an objective every day, if not every hour. Again, what would be the best vital signs? Vital sign, I would say, for an injured brain? I'm pointing toward something that is called PRX, which was developed in a research center in the University of Cambridge through a system that measures multimodal analysis that analyze P wave of an ICP. So if you analyze P wave, you end up having, I'm sure everybody here knows which one, where is the P wave. I will skip those slides. This is A waves. So the PRX is a global index for cerebral vascular reactivity. And this is a complex index that measures the variability of the P wave of the ICP, ending up giving you at the end the relationship between the systemic blood pressure and the ICP. So you decide every time how does your brain react to each pulse from your heart. This measurement is done over 6 to 10 seconds, and you end up having the cerebrovascular pressure reactivity index, the PRX. So the PRX here is a vital sign that is dynamic. You can measure it whenever you want. You can have it every 6 hours. You can have it every day. And based on that, you react. You decide how good is or how intact is your cerebral autoregulation. A positive number is, or a positive digit of PRX is associated with pathologically preserved non-reactive cerebral vasculature. So any increase in the blood pressure will go with it an increase in the ICP and the pathology of high ICP, such as brain edema or hemorrhages, based on the pathology of the disease. Negative values, or a cutoff point of less than 0.25, indicate an intact reactivity. So your blood vessels in the brain is still healthy to some extent, and they can manage the variabilities of the systemic blood pressure. The PRX, as a vital sign, will give us a hint to have an optimal patient's optimal CPP, or customized cerebral blood pressure. So when you customize this number, you will have a daily goal, or I would say probably, let's say a daily goal. Patients change usually over hours. Let's say you will have a daily goal of an optimum cerebral perfusion pressure based on the PRX number. And so then you will manage that patient differently every day based on his PRX. This is the number, is 0.25. That indicates healthy autoregulation. And if you have this number positive or more than 0.25, the index itself, you will have the linear relation. So you push blood and the blood goes with it, the edema of the brain, and then the worsening of the ICP. This is a diagram that indicates what happens if you mispoint your cerebral perfusion pressure. Let's say if you either under or over perfusing the brain. If you're under perfusing the brain, this is the cutoff point, which is 0.25, you will end up by having ischemia. And if you are overshooting, let's say, for example, on the first day, you decide to do induction of blood pressure with the inotropes, and you keep that ongoing, and you overshoot, then you will have the brain edema or the hemorrhages. And both are bad. The relation of the ICP to this PRX is basically, you will have a steady ICP all the way. However, under the surface, in the last spectrum, you will see the variability of the PRX. We will not be able to understand this without knowing the dynamics of the autoregulation. So the ICP per se, for people who just depend on ICP, will look to be normal. They will not consider this that the patient is changing, is getting worse. But if you go and see under the surface, if you go and see under the water, there is many things are happening and they're changing and responding to the patient brain and the hemodynamic status. Too low is bad and too high is bad. I have 1 minute, I have to finish. Correlation is there for TBI. PRX correlates very well with outcomes. Let me skip those 2 slides. This is a very important slide. So if you mispoint the optimal cerebral perfusion pressure, if you go down, more patient will die. If you go higher, more patient will live, but with more or severe disabilities. This is a case scenario of a patient who had a traumatic brain injury, and before the ICP shoots up, let me just show you. This is the PRX worsening, and this is the ICP jumping sky high. So you see, every day is the graph shows days. So from day 5 till day 7. I'm sorry, from day 1 to day 7. You see the PRX change started before, and the ICP was late. Many things could have been done for that patient, like craniectomy, hypothermia, sedation, hyperosmolar state, to manage the impairment in the ICP. Okay, so with that, because I have 1 second, I would love to invite you for the coming, coming Society of Critical Care Medicine conference. That's next month. It's going to be between us and Riyadh. And can I go? So with that, actually, I would love to conclude. And thank you very much.
Thank you.